This year's Hephatos celebrates 20th anniversary, and they don't live on past glory. They are hardworking, so they managed to organize such an event in this turbulent COVID-19 time. So co-organizers of this event are Croatian Academy of Sciences and Arts, Department of Medical Sciences, World Health Organization Office in Croatia, Croatian Society for Internal Medicine Oncology, Croatian Oncological Society, Croatian National Reference Center for Diagnostic and Treatment of Viral Hepatitis of the Ministry of Health, Croatian National Reference Center for Chronic Liver Diseases of the Ministry of Health. So, ladies and gentlemen, on behalf of the organizer, Croatian Association for the Liver Diseases, Hephatos, President of Association, Mrs. Tanja Rejić, will welcome you. Tanja, without applause, unfortunately. Tanja Rejić, yeah!
Thank you, Daniela. Dear esteemed participants, dear doctors and experts, dear representatives of global, European and national institutions and government, dear fellow patients, it is my extreme pleasure to welcome you all at this high-level event under the patronage of Croatian presidency over the Council of European Union. Today, but not only today, I'm very proud of accomplishments Hephatos achieved in the last 20 years of its commitment to liver patients. As you can see, agenda looks and is very busy, so I will immediately stop here and let esteemed distinguished guests to welcome you, as well as say in more details importance of this event focus on hepatocellular carcinoma, entitled, as Daniela has already said, HCC An Avoidable Fate. Thank you very much, and I wish you a good conference.
Thank you, Tatiana. We spare a lot of time. Our distinguished guests will address you, ladies and gentlemen. At first, Head of World Health Organization Country Office in Croatia, Antoinette Kajićrak.
Thank you, Daniela. Dear organizers, dear Tanja, distinguished colleagues, allow me to address you with a few words on behalf of the WHO Country Office in Croatia. We are participating in a video conference due to the present COVID-19 pandemic. However, viral hepatitis pandemic is also an important international public health challenge which has been largely ignored as a health priority. However, adoption of the resolution on 2030 agenda contributed to growing recognition of its massive public health burden called for scientific action to combat viral hepatitis and emphasize the huge opportunities for action. Viral hepatitis is responsible for an estimated about 1.4 million deaths per year from acute infection and hepatitis-related liver cancer and cirrhosis, which is comparable with deaths due to HIV/AIDS, malaria, and tuberculosis. With the introduction of highly effective prevention measures and treatments, global elimination of viral hepatitis is a realistic goal to which all WHO member states have agreed to by achieving a global reduction in hepatitis-related deaths by 65% and new infections by 90% by 2030. Each member state, however, defines specific national targets concerning mortality and incidence based on their local epidemiological context, with the milestones for 2020 defined as 30% reductions in new infections and reductions in hepatitis-related deaths. Action Plan for Viral Hepatitis in WHO Euro region adopted the Global Health Sector Strategy on Viral Hepatitis 2016-2021 to the Euro regional context of universal health coverage, emphasizing the importance of public awareness, effective prevention, available diagnostics, and affordable hepatitis treatment, with commitment to achieve health equity. Member states in our region enhance political commitment to control viral hepatitis, which is evidenced by an increase in the number of countries who either already endorsed or are in the process of delivering and developing national hepatitis prevention and control strategies and action plans. Croatia we have a draft plan, and I think hopefully relatively soon, I hope we will endorse one as well. I would like to mentioning the importance to emphasize that national planning based on evidence while enabling inputs from all key stakeholders, including contribution from civil society in addressing policy development, service planning, and resource allocation, should advocate for political commitment for sustainable financing and national ownership. By this, I wish you a successful conference, hoping that the next meeting will take place in a completely COVID-free environment. Thank you.
Thank you. It was Antoinette Kajczak from WHO in Croatia, so it's time for WHO Regional Office for Europe and Mr. Masoud Dare. Few seconds more, s'il vous plaît. Okay, welcome.
Ladies and gentlemen, dear colleagues, friends, patients, and community representatives, I hope you're all doing fine during these trying times.
Okay.
On behalf of WHO Regional Office for Europe, I would like to welcome you to this important meeting. I would also like to thank the Croatian Association for the Liver Diseases, Hepatos, and also our host for organizing this event. Most of us may have come across the phrase, "the world has changed." It is hard to disagree with this statement, particularly during the COVID-19 pandemic. Individual and collective new challenges have presented themselves every day, requiring from all of us a full exercise of our humanity, empathy, tolerance, and cooperation. The circumstances are exceptionally unique today. This is definitely not our first time facing an important public health challenge.
There is no sound.
Particularly with infectious disease, which we don't have yet effective vaccine or antibiotics. Just a few years ago, we were still struggling with hepatitis C, a viral infection without an effective treatment free of adverse events. Together, and backed by scientific evidence of the highest quality, we have worked out not only on the development, implementation of the highly effective treatment, but also significantly improved public health policy worldwide, leading to a global effort of hepatitis elimination. The world has changed, indeed. However, our mission, health as a human right, has not and remains our daily concern. Our determination and efforts shall increase, however, with every new challenge, seeking to protect lives regardless of age, gender, sexual orientation, socioeconomic status, or ethnic background, with every new challenge. Ladies and gentlemen, speaking of the main reason we meet today, cellular carcinoma or primary liver cancer, this long-term consequence of chronic viral hepatitis cannot be understated. In our region alone, it is estimated that about 50,000 people lose their lives due to hepatocellular carcinoma every year. This is 50,000 too many and shall be prevented. Invisible to the naked eye, mostly asymptomatic until well advanced, a comprehensive response to hepatocellular carcinoma spans across different levels of prevention, testing, treatment, and care. We need to scale up all the efforts and implement public health approach through people-centered care and reaching out to the key population groups. For example, people who are injecting drugs and prisoners, which are often underserved. Additionally, we have older generation who may have been recipients of unsafe blood or blood products at the time when not only we lacked treatment, also to these diagnostic tests for hepatitis C were not available. Hepatitis B vaccination is one of the most powerful public health interventions which can prevent hepatocellular carcinoma. As you know, this is the first cancer-preventing vaccine which is developed and now widely used worldwide.
I don't know.
And
Does
showing
anybody
already
have sound or
effectiveness in
not at all?
reducing the burden of
Not
chronic
at all.
hepatitis B
Not in Bulgaria.
and consequently associated hepatocellular carcinoma.
So it's pointless to continue with this.
If
Can
you
we
make
stop
sure
this
the
and start
immunization
again?
coverage is increasing
No,
and no one is left behind.
not in Bulgaria.
More recent interventions
So it's
effective
pointless to
treatment
continue
of
with this. Can we
hepatitis
stop
C
this
and B
start again?
bring us even closer to the goal of hepatitis elimination. Today's event is an excellent opportunity to review the good practices in the health sector response to viral hepatitis and hepatocellular carcinoma prevention and care. During this event, in addition to reviewing many of those achievements, we shall also discuss challenges and way forward, making sure there are no setbacks and the continuity of services will be assured in the path of wider access to medical advances and the elimination of one of the major public health challenges of our time. I would like to once again reiterate the essential role each of us shall play in hepatitis response. Building on a strong and continued government commitment and European solidarity, we need to have national action plans which are fully funded and sustain strong partnership, particularly with the patients and communities. To the people living with viral hepatitis or hepatocellular carcinoma and their loved ones, our most respect and firm statement that WHO will continue its efforts and advocate for stronger national, regional, and global responses. Taking the opportunity, I would also like to invite all key partners to join the regional collaborating committee on a TB, HIV, and viral hepatitis, which is a platform hosted by the WHO Regional Office for Europe for advocacy and exchange of insights among key partners to end 3 diseases by 2030. I wish you all a very successful meeting. Thank you very much for your attention.
Thank you very much to Mr. Masudar. Ladies and gentlemen, I'm afraid we have a little technical problems. We'll try to solve this, but we have to go on. So after Mr. Masudar, it's time for the Vice President of the European Commission, Mrs. Dubravka Šuica.
Umbrella of the Croatian presidency of the Council of the European Union. I understand that this occasion marks the first ever gathering of experts with this background and goal in the Republic of Croatia. I congratulate Hepatos on the great work they do alongside the many other research and medical institutes in Croatia, as well as the Croatian Ministry of Health and elsewhere across the Union. As I have myself been engaged in supporting the fight against cancer and in raising awareness on this issue throughout my political career, I thank you for your invitation and for the organization of this important event today. Ladies and gentlemen, I applaud the ambitions of the participants here today to keep viral hepatitis elimination goals high on the list of priorities. It is indeed vital to reinforce the progress already made in health efforts for the betterment of liver patients. By working together in the European Union, by supporting the World Health Organization and their efforts to eliminate hepatitis, you have ambitions to reduce the hepatocellular carcinoma incidence in Croatia, in the Western Balkans region and across the European Union. President von der Leyen attaches great importance to the fight against cancer. She made Europe's Beating Cancer Plan one of the priorities of this Commission. Our aim is to support Member States to improve cancer prevention and care and to strengthen our approach through all stages of the disease. Europe's Beating Cancer Plan will be adopted under the guidance of my dear colleague and friend, the Commissioner for Health, Stella Kyriakides, in the fourth quarter of 2020. In addition, the Commission advocates for a close link with the research mission on cancer in the Future Horizon Europe programme. In our efforts to fight diseases, we achieve most when we work closely together and share our research and ambitions as during the current COVID-19 pandemic. The European Union-funded Clinic Impact project has successfully developed a clinical simulation tool to improve the safety and success of radiofrequency ablation for the treatment of liver cancer. And of course, as Vice President for Democracy and Demography, I must mention both the Conference on the Future of Europe as well as demographic trends. As we engage with citizens on the future of Europe, I am convinced that citizens' expectations and concerns regarding health and healthcare will be central topics. Likewise, demographic developments inform and shape the way in which we approach health and healthcare. This needs to take into account increasing life expectancy, population aging, the diseases that come with it, as well as the differences we can detect between member states, regions, women and men. Dear ladies and gentlemen, when it comes to our health and healthcare, to beating cancer, to facilitating the necessary research to build a better health system for tomorrow, it is only together that it can successfully reach its full potential. This is illustrated by today's event. I wish you all a very stimulating debate throughout this conference, and I look forward to learning of your conclusions.
Thank you to Mrs. Dubravka Šuica, and ladies and gentlemen, envoy of the President of Government of the Republic of Croatia and Deputy Health Minister of the Republic of Croatia, Mr. Željko Plazonić.
Participants, it is my great pleasure and honor to address you today in my capacity of envoy of the President of the Government of the Republic of Croatia, Mr. Andrej Plenković, on behalf of the Minister of Health, Mr. Vili Beroš, and on my own behalf. While the planet is facing the COVID-19 pandemic, which certainly needs our full attention, as it has affected more than 6.5 million people so far, we cannot abandon the progress we have made in the fight against liver disease and should at least try to keep the current status and avoid taking steps back so that we do not lose the achievement momentum in eliminating viral hepatitis as well as other liver diseases. Viral hepatitis is an important public health problem in Europe, taking the lives of over 160,000 persons every year. Most of these deaths are caused by untreated chronic hepatitis infections, resulting in cirrhosis and liver cancer. Today, chronic viral hepatitis infections are thought to be responsible for about 2/3 of all cases of liver cancer, the most common cancer in many parts of the world. Viral hepatitis is specific due to its quiet clinical course, so most patients with chronic B or C hepatitis are not aware of their disease at all and are therefore not recognized, treated, and are a constant source of infection. The vulnerable groups most commonly affected by this infection require specific approach aimed at accessing services and removing barriers caused by poverty, marginalization, as well as stigmatization. Like other member states, Croatia is continuously implementing activities to combat this infection. We have directed our role of the national level towards activities and goals that will certainly contribute to positive changes on the international scene as well. We are very proud to say that our activities are also carried out in a partnership with the association Hepatos. However, our actions have to be more effective and determined. We strongly support the messages from today's event aim at raising awareness of the problem of viral hepatitis and allow me to emphasize that only by working together we can achieve far greater results in this area for the benefit of all our citizens. Thank you very much.
Thank you to our honorable guests, ladies and gentlemen. We have a lot of work to do. So it's time for first presentation. The presenter is head of Croatian Society for Internal Medical Oncology, Professor Strijepko Pleština, and the topic is state-of-the-art lecture, HCC Key Problem.
Fine. Ladies and gentlemen, dear colleagues and friends, first of all, I wish to thank a lot, thanks to organizer giving me a chance to talk about hepatocellular carcinoma, tumor type among those with the worst prognosis till our days, despite all advances we reached last years in therapeutic options. So it's a sixth cancer entity and a fourth cancer cause of death worldwide. It's above 90% of types of primary liver tumors. What is very important, mortality to incidence ratio is about 90% or more than that, making it the major cancer entity with the poorest prognosis still our days. So the global incidence is highest in developing regions. More than 80% of new liver cancer cases occur in less developed regions, with more than 50% of world cancer new diagnosed reported in China alone. While Japan and China have started prevention programs like hepatitis B virus immunization or education in exogenous toxins, global HCC numbers are still rising, with Western Europe countries seeing 2 to 7% increase per year. So the incidence among the European countries differ. From Southern Europe, about 11%, to Central Eastern, about 6.2% in male. So men have a roughly threefold higher risk of developing liver cancer than women. What is the situation in Europe? So if we compare Moldova, more than 14% or more than 14 in male, to Norway, about 2.2, and Croatia in between, with 7.7. So in Croatia, the hepatocellular carcinoma is 10th cancer entity and 7th cause of cancer death in males. So what is the most important cause of HCC in the world? Hepatitis C virus is highly associated in West Europe, in North America, and Japan. On the contrary, in Asia and Africa, hepatitis B is predominant etiological factor. So nowadays, non-alcoholic liver disease is associated with obesity and diabetes becoming every day more and more important risk factor for developing hepatocellular carcinoma. It's not working. Oh, sorry. Let's go back. So, more than 90% of hepatocellular carcinoma are of known underlying etiology, differing between European countries. In eastern part of Europe, alcoholic disease is predominant, more than half cases. On the contrary, hepatitis C virus is in Western Europe predominant. So, viral hepatitis is the most common risk factor for HCC. That is the well-known fact for more years. Most cases associated with B and C infections occur on a background of cirrhosis. In contrast to C infection, B hepatitis can also be directly oncogenic without development of cirrhosis, probably through integration in a cell DNA and consecutive alteration of tumor suppressor genes. So about 15% of patients in normal liver can arise HCC, so without cirrhosis. Predominantly, more than 85% of patients have chronic injury in background of tumor development. So clearly, we have evidence for cirrhotic patients, A, B, or C, according to Child-Pugh stage, with a rather low level of evidence, but strong grade of recommendations. Interval of surveillance should be dictated by rate of tumor growth and tumor incidence in a targeted population. So the optimum is 6-month interval. We know that 3 months interval had no clinical benefit in clinical studies. On the contrary, 1-year interval, we can detect fewer early-stage diagnoses compared with short interval. So I wouldn't go to details, but nowadays we have a clear algorithm for diagnosis and recall in patients with cirrhotic liver. Clinicians must balance a broad range of factors in order to reach optimal treatment option. So we have a tumor, we have malignant disease, but at the same time we have a liver disease causing liver insufficiency, and that despite of tumor progression. So a lot of colleagues should be present in determining the option of the therapy. Oncologists, hepatologists, gastroenterologists, surgeon, interventional radiologists, taking account tumor number and tumor size, but also liver disease. Of course, preference of patient, age, comorbidities are the factors that we must include, taking account the optimum for the patient. So, staging of tumor is not easy. Usually we use in oncology TNM classification. We determine the tumor, the nodes, and the spread, metastatic spread. But while TNM classification is a standard, in other entities, TNM system is only one piece of the HCC puzzle. Usually in Europe and also in States, we use Barcelona Clinical Liver staging system. That's a most commonly used staging system. Why? Because it takes account patient status, liver function, and tumor stage. What all we need to clearly have the best treatment option for the patient. Of course, Child-Pugh score is used for assess liver function. So we include in BCLC staging system also Child-Pugh score. A declining liver function has implications on available treatment options. Some procedures become contraindicated because we can cause further damage and further deterioration of liver function. If we look at proportion of disease stages at diagnosis, although treatment rates differ across the globe, initial staging tends to be similar, irrespective of region. So approximately 50% of patients present with advanced HCC. Initial symptoms of the tumor might be masked by the underlying liver disease. Not all patients could have benefit from local regional interventions, and the majority of them will require systemic treatment. Systemic manifestations of cirrhosis, like ascites, gastroesophageal varices with high risk of fatal bleeding, hepatorenal syndrome, or hepatic encephalopathy, can cause deterioration of performance status and an ability to treat the patients with specific oncological treatment. What treatment options we have nowadays in advanced HCC? So, as a first-line treatment in those with early-stage disease, of course, surgical treatment is the best solution. Resection or liver transplantation, those who are able to have that kind of treatment. Local ablative techniques like transarterial chemoembolization are also a possibility. But a lot of people, more than 50%, have advanced disease. So they are candidates for systemic treatment. Unfortunately, part of the patients are not able to receive specific oncological treatments. They are candidates only for best supportive care. So advanced HCC still has limited treatment options that is still unmet need, despite the fact that we have advanced last years. Transarterial chemoembolization is the procedure that can induce complete response in a number of patients, but also at the same time reduce liver function due to ischemic damage to non-tumor affected liver tissue. So as a result, patients treated with TACE may be kept for observation in a hospital. So TACE use differs across the globe, dependent on underlying disease, resources, and local preferences. In America and European countries, guidelines favor the use of TACE in patients with good liver function without macrovascular invasion or extrahepatic spread. So, unfortunately, just about 20% of patients stage C will receive TACE. So systemic treatment on those patients are something that we need to apply. The first positive phase 3 study, randomized prospective placebo control, was SHARP study, showing us that sorafenib can reduce risk of death about 30% compared to placebo. That was the first positive study in hepatocellular carcinoma with a systemic treatment, just in patients with Child-Pugh-A cirrhosis. After that, levantinib showed non-inferiority to sorafenib in a REFLECT trial, so that is the alternative for the first-line systemic treatment of patients. But unfortunately, the effect is quite low. The overall survival is about 1 year, together with second-line treatment about 15 months. So the systemic treatment still nowadays is not satisfactory, despite the rapid progress that have been shown in first-line systemic treatment in recent years. So recently, we have results of use of immunotherapy. Cancer immunotherapy can target multiple immune checkpoints involved in reviving the immune response, showing us very, very nice results in some tumor types like melanoma, like lung or kidney cancer. But unfortunately, monotherapy had no benefit in patients with hepatocellular carcinoma, neither with nivolumab nor with pembrolizumab. But what can we do? Liver is characterized by a strong intrinsically immunosuppressive microenvironment. So, if we can combine immunotherapy, checkpoint inhibitors, with other agents like vascular inhibitors or tyrosine kinase inhibitors, then together we can reach the better results. Last year's, so we have another chance to better treatment for our patients, and recommended systemic therapy for unresectable HCC has been better results, and I hope next year's we will have the better results in the treatment of patients with advanced HCC. In the meantime, the prevention and early detection are the best options for our patients. Thank you for your attention.
About Europe's beating cancer plan, Liver in Focus. A lot about it knows our next presenter. He is Chief Executive Officer and member of the Board of Digestive Cancer Europe, Mr. Stefan Jessel. I apologize in advance for incorrect pronunciation. It's always tricky with the names.
Good morning. My name is Stefan Jessels and I represent Digestive Cancers Europe. This morning I will talk to you about the European Commission's Beating Cancer Plan. But I'll start by introducing myself. So I am a metastatic colon cancer survivor myself, treated in 2015, and a happy survivor today. I'm also the CEO of Digestive Cancers Europe, co-chair of the Patient Advisory Committee of the European Cancer Organization, and co-chair of the Scientific Committee of Sharing Progress in Cancer Care, and also the co-founder of the Belgian Patient Expert Center, which is a training center for patients who want to become patient experts. Let me first introduce Digestive Cancers Europe. We're an organization that represents 30 national organizations active in one or the other digestive cancer, so including esophageal cancer, gastric cancer, pancreatic cancer, liver cancer, colon cancer, rectum, and more rare cancers. Who know or may not know, every year 900,000 people get a diagnosis of one or the other digestive cancer, and 600,000 of them die, unfortunately. You can see that liver cancer represents around 90,000 patients and 80,000 of them die, so very high mortality. And so very important to have action on that level. Luckily, today the European Commission has made cancer a priority, and I think more would have happened in the past few months if the COVID-19 crisis had not attacked us since the beginning of this year. So it is their deliberate plan by Ursula von der Leyen to work in the next 5 years on cancer as a priority for health. And there are two programs that need to be explained. The first one is from the Director General responsible for health. It's the Beating Cancer Plan, led by Commissioner Stella Kyriakides from Cyprus, who, by the way, is a patient herself, a survivor, a breast cancer survivor. And she used to be the chair of the Patient Advisory Committee of European Cancer Organization, the role that I have now today. Second project is by DG Research. It's the Cancer Mission, led by Commissioner Maria Gabriel from Bulgaria. These are two initiatives from the European Commission on cancer, and they are interwoven, so they connect somehow in making sure that the right things are happening. And then a third initiative by the European Parliament is that for the next 12 months there will be a special committee on cancer, and they will track whatever the Commission is doing to make sure it's well connected, well organized, and well funded. All information about that, of course, can be found on the website of the European Commission. So why this plan? And why this focus on cancer? First of all, and these are slides from the European Commission, is that cancer is a very broad term that covers over 200 diseases. As you've seen from the statistics, many patients get diagnosed every year, and 40% of people are at risk to have cancer at one time during their life. So it's a very high incidence for citizens in Europe. Furthermore, 4 out of 10 cancers are preventable. So efforts need to be made to make sure that people have the right lifestyle choices. And as you can see, only 3% of the health budget is spent on promotion and prevention of the diseases. It's also a challenge because all cancers are increasing in Europe. Why? Because of the aging of the population, because the populations become younger, but also because lifestyle is not improving. So many cancers are also linked to, for instance, overweight and obesity, unhealthy foods, alcohol consumption, smoking, etc. The European Commission calculates the cost of cancer at 100 billion euro annually. Our calculation or other people's calculation shows that it's double that amount, 200 billion euro. So the economic costs are also huge. And so any investment to make people live better and longer also will have a positive impact on the economy. So the Commission, beginning of this year, on February the 4th, presented the roadmap for the Beating Cancer Plan. And the roadmap actually consists of 4 big buckets: prevention, diagnosis, treatment, quality of life of patients and carers, and survivors. Within the prevention bucket, they come to the conclusion that 4 out of 10 cancers are preventable. So that means that within the plan, they will look at measures to make sure that unhealthy lifestyles are discouraged. Taxation for tobacco products and alcohol consumption is one measure and instrument they have to force people actually to change their lifestyle. They will also look at exposure of carcinogens in the workplace, like in chemical companies, or in cafes and pubs where tobacco smoke is available, and of course also in the environment. And then the last is make sure that the foods that we have are healthy from farm to fork, so that pesticides, insecticides, and other chemical residue does not affect our health negatively. The second bucket is diagnosis. To address gaps in knowledge, what can we do to make sure that patients identify their disease much earlier, so that they don't wait till the symptoms have aggravated to such a level that treatment is no longer possible. Look at digitalization to reduce detection time, and as you know, already tools are available, for instance, for melanoma to identify brown spots on the skin, making it possible for patients to self-diagnose and go to their doctor and have an earlier intervention than when it's in a metastatic stage. Technical support for member states. The European Commission has also and already done so, for instance, in colorectal cancer screening. They've given support to countries like Italy, Poland, Romania to work on screening programs, and then regulatory support to reduce inequalities. The third big bucket is treatment of the disease. Treat improvement times so that patients have faster recovery, less complications, shorter stays in hospitals, but also incentivizing innovation, pharmaceutical strategy for affordable therapies. And they're working on a specific program next to the Beating Cancer Plan, specifically for pharmaceuticals. There's the European health data space, which looks at which data are really important for us to aggregate at the national level to identify where best practices are being used and what can be done to make sure these best practices and research data are shared among the member states, among the medical community, to make sure that progress is being generated. And then the fourth bucket is quality of life for patients and survivors. And there again, the patient community will be very critical to give insights to the European Commission about what patients want in terms of quality of life and what it means for patients and caregivers. One topic, for instance, is discrimination. Discrimination among patients because of age, because of gender, because of ethnicity, but also to make sure that there is equal access for everybody to the healthcare system within one country, but also compared to the different countries. People also get discriminated because they are cancer patients. If you want to go back to work or you want to have an insurance or you want to travel abroad, you cannot get an insurance because you're a cancer patient. And these are things that need to be addressed, and the Commission is very open to listen to ideas on how to make that forward. Psychological support, as you all know, having cancer is more than having a physical illness. It's also the context in which you work. It's your relationship, it's your social environment, it's your work environment. And then last but not least, it's back to work support for patients once they are free of cancer or their cancer is in a manageable state so that they can start working again. So this is the roadmap that the Commission developed, and that was presented on February the 4th, beginning of this year, at the occasion of World Cancer Day. The Commission has been very open, and the Commissioner specifically. She has consulted with a number of patients, patient organizations, NGOs and others in the course of this year. So until the 4th of May, everybody could complete a questionnaire on the website of the European Commission, and that is taken into account by the Commission to make sure that they can work on it to finalize the roadmap. The second phase, and that's between now and the end of the year, gives the opportunity to other organizations to interact with the European Commission, to give their comments and suggestions to finalize the plan. And that's the phase we're in now. So far, the Commission has received 387 submissions by member states, by third countries. So these are countries outside of the European Union. And you can see by NGOs, citizens directly, companies, business associations, research and academia. The majority of the recommendations were on prevention, treatment, quality of life, and diagnosis was the least commented upon. So, to conclude, this is the plan of the European Commission. This is their very high-level roadmap that will be finalized, prioritized, and communicated originally at the end of this year, but possibly because of the COVID crisis that will be extended to the beginning of next year. What about liver cancer in this context? Well, we as Digestive Cancers Europe represent the liver cancer organizations in the discussion we have with the European Commission. So I'm part of a European Cancer Organization. We had a call with the Commissioner 2 weeks ago, but we are also in direct interaction with DG Sante and the Commission to make sure that they understand the needs of digestive cancer patients, and then of course specifically for each of the digestive cancer tracts. And we'll make sure that for every type of digestive cancer we will have some recommendations. How we will do that, we'll work with the national associations and with ELPA to come with a concerted approach. So that's what we can do at the European level to make sure that the policymakers understand and hear what's needed to be done. Once that text is available and these recommendations are on paper, you can also use them to influence your national politicians and policymakers about what can be done and what needs to be done. So this is, in a nutshell, very briefly where we are and what can be done at the European level with regard to the Beating Cancer Plan. So it's still open at the moment. We have the time frame of till the end of the year, probably a little bit less, to give comments and suggestions to the European Commission, after which the plan will be rolled out and communicated and rolled out for the next 5 years. One more thing that I forgot to say is that the European Commission has made a significant amount of money available for the next 7 years, namely 9.5 billion euro, to address the context of health in Europe after the COVID crisis. Not all that money will go to the COVID issue. It will be used to prevent pandemics, cross-border healthcare will be improved, and the Beating Cancer Plan will also be financed from that budget. So that's an increase. Today it's 400 million euro, and they increased it to 9.5 billion euros. So that's a significant increase in the budget, and we all hope that we will get some money from that to make sure that we can work with this. So thank you for your attention, and if you have questions, you can address them to me, but in the meeting is my colleague also Zorana Maravic from Belgrade, and she will be able to answer your questions too. So thank you for your attention. Address them to me, but in the
Thank you to Mr. Stefan Gisel. Tatiana Rage said that it was a very useful and clear presentation. Thank you once more. Ladies and gentlemen, you know we divided this event, this session, in 2 parts. First part is titled From Elimination to Prevention, why this is important, especially in COVID-19 era. After that, we will talking about not about our non-alcoholic fatty liver disease, but in general. So we started this first part. The introduction presentation will give our experienced expert, the head of Croatian National Reference Center for Viral Hepatitis of the Ministry of Health, Adriana Vince. Professor Vince knows after Europe's Beating Cancer Plan what's going on in Croatia, in our backyard. We will hear right now. Because Professor Vince will talking about national program for the elimination of viral hepatitis and conclusions of HCV disease burden modeling in Croatia. And after that, we will ask ourselves where we got stuck in this part of Europe. We want to mention always that we are part of Europe, so maybe in Croatia we can be satisfied, or okay, we will hear soon. Are we prepared? Okay. Adriana, speak from here.
Okay, so ladies and gentlemen, dear colleagues, first of all, I really want to thank and congratulate the organizers for organizing such an important meeting at this era of COVID, that we found the strength to move from the subject of COVID-19 and move on to our older patients, old problems, patients that are still in need. So just shortly to introduce myself, I'm infectious diseases specialist, professor at Zagreb Medical School, University of Zagreb, and I'm also head of referral center for viral hepatitis in Croatia. Okay, so I will just give you an overview of the epidemiologic and treatment data for Croatia, and also give you some insight into the conclusions of HCV disease burden modeling in Croatia paper that we have just submitted for publication together with specialists from CDA, Center for Disease Analysis from USA. So please, can you just move the slide? Okay, so the whole idea, as already was mentioned, but it should always be repeated, started in 2016 when the World Health Assembly endorsed the elimination of hepatitis as a public health threat by 2030. So this elimination, what does it really mean, this plan? To reduce the incidence by 90%, to reduce mortality by 65%. What would be the implications of that plan? Countries should formulate plans, and WHO watches and reports on progress. So global health strategy is there from 2016. There is also regional action framework, also for European region, and the national strategies or plans are being pushed to be done for each country. You can see the progress from countries in European region, from 13 countries who had originally planned in 2013 to 32 in 2019. As you can see, Croatia here still yellow, so still not endorsed action plan, I have to say. So just baseline epidemiologic and disease burden data. Shortly for Croatia, we are a rather small country, 4.2 million of inhabitants. Just to give you the idea, here are the basic data on public health criteria that we always look at. And regarding HCV epidemiology in Croatia, the prevalence in general population is 0.9. So we think, our epidemiologists think, that we have about 35,000 anti-HCV positive people. Of course, the prevalence in people who inject drugs is much bigger. It goes up to 65%. Also, in prison population is up to 40%. In HIV co-infected people, they are only 5% of those patients. Hemodialysis is nowadays neglectable, in blood donors as well. And children and adolescents, according to newest studies, is really low, and in pregnant women also 0.5. So these are the basic data to start with. And if we look at the HCV incidence by years till 2018, then you can see in years 2000 till 2005, we had numbers of more than 500 detected and newly diagnosed people with HCV infection. This was the interferon era, when we treated also a lot of patients with interferon. And afterwards, you can see a decline in the numbers of newly diagnosed cases because there was no therapy, so also people were not looking for the disease, obviously. But since 5-6 years, again, on an annual basis, we see about somewhat more than 200 newly diagnosed cases, so it will also be the case for 2019 as well. I will show you the prevalence by age and gender comparison. This has been done recently for the years 2017 and 2018, and you should pay attention to the bold blue line on both slides. So you can see we have a kind of biphasic gender and age distribution. So we have younger patients from about 40 years, mostly people who inject drugs. And the second phase, as you can see, are the patients around 60s, and they are those ones that received infected blood. So we still see those patients, and on average, the age of a patient when he first comes to a doctor with diagnosis of HCV would be about 45, 49 years of age. When we look how bad is his liver already being damaged when he first comes to see doctor, you can see the trend through the years that the patients come as late presenters. That means, if you look at the right side of the slide, for year 2018, already 60% of patients have F3 or F4, so we call them late presenters because they have already severe fibrosis when they come to see the doctor for the first time. So about the incidence of hepatocellular carcinoma in Croatia, This is the slide that I got from National Cancer Registry, and here are only the histologically proven hepatocellular carcinomas. So you can see the increase in the numbers through the years, and this trend is still continuing. If we look up to 2016, you can see that trend in incidence and mortality from hepatic carcinoma for Croatia. They are slowly but surely rising. So those are the solid data we have regarding hepatocellular carcinoma in Croatia. We are also doing efforts to increase the number of patients being treated with direct antivirals. So this is a situation that is being improved from year to year. For 2019, we have already treated about 500 of patients, and SVR is as expected with those fantastic new drugs. It's about 97% of those patients, they got rid of the virus. Okay, so this is how much patients we find per year and numbers that we treat. We have just recently published the paper, How Close Are We to Hepatitis C Virus Elimination in Central Europe, also with colleagues from Central Europe. So you can see the data for Bulgaria, Croatia, Czech Republic, Hungary, Latvia, Lithuania, Poland, Slovakia. And what is interesting to see here is the importance of several criteria for the elimination in Central Europe. And you can see that very low scoring was actually given to political will. It is 16. Then national screening program, it scored altogether 11, and linkage to care programs, which is actually 17. So most of the participants, they concluded that the access to therapy is similar and good in the majority of patients, can be treated according to current guidelines in Central European countries, but there is a lack of political will to implement national screening programs. And so, by the data that we had in this study, HCV elimination will not be possible in this region by 2030. Okay, so in Croatia, we also have done the recent study with Center for Disease Analysis, which is disease burden and strategies to minimize the future burden in Croatia. As you know, the CDA has this disease burden model, which simulates disease progression over time. It takes the data for a country, epidemiological data, and then models the disease progression in years and number of patients that will get to hepatocellular carcinoma, decompensated cirrhosis, and those that will die. This is a very sophisticated progression model. I will not go into the details. It has been used in global modeling study that has been published in 2017. According to data we had now with CDA, if we continue treating patients like we do now and screening like we do now in Croatia, we will still see 140 new infections every year, which I believe is very true. So if we also continue to treat and find the patients according to current standard of care, then unfortunately now we screen about 30,000 people every year. The annual number of newly diagnosed and treated patients would be expected to drop starting in 2022, but this will be mostly because some people will die because of end-stage liver disease. So we did a few modeling scenarios, and by this first case-based scenario that we do now, we can see we can expect from 2022 drop of number of cases, but if you look at the incidence of decompensated cirrhosis, it will grow. HCC, as we have already shown, still will grow till 2030, and liver-related deaths will still grow. So, of course, this scenario we are doing right now is not good. So we have simulated few scenarios and found, according to this model, found the best model, which is that we should enrich each year the number of screened patients, and we should come to a number of about 100,000 patients that we should screen up to 2024, and also treat annually more than 1,000 patients in order to finally meet the criteria of WHO. So you can see the green line. This is something that we have to achieve if we want to meet the end criteria of WHO. And there is obviously a lot of work in screening, especially in screening, and then follow-up in treatment and linkage to care, if we want to do this goal of WHO. So this can be achieved, but a lot of efforts should be undertaken to increase both screening, treatment, and linkage to care. As a conclusion, I have to say we really have to go in bigger numbers, and this can only be done by comprehensive planning, which we try to do in drafting the action plan for Croatia. So for the time being, thank you for your attention.
Thank you to Professor Adriana Vince.